Hey everyone, welcome back. I am so thrilled to have you here with us for another explainer. Today, we're tackling a totally critical area that honestly trips up a lot of seasoned professionals: nursing facility services. Specifically, we're looking at CPT codes 99304 through 99316. Now, if you've been working in medical coding or billing recently, you already know that the 2023 CPT Evaluation and Management Guideline overhaul completely shifted the landscape. I mean, it was a game changer. History and physical exams, they are no longer the deciding factors for your code levels. Instead, it all comes down to medical decision-making, or MDM, and total time. So, as your coding instructor, I'm going to guide you through exactly how this massive overhaul impacts nursing facility care. We're going to map out the entire patient journey, literally from admission all the way to discharge, to make sure you understand exactly how to secure your revenue and stay compliant. Okay, let's dive into the syllabus. We'll start with the framework updates, then walk through initial care and subsequent care, cover the discharge rules, and finally finish up with the audit red flags you need to watch out for. All right, Part 1, Nursing Facility Framework Updates. Let's look at how the 2023 consolidation really simplified things for facility coders. But before we start throwing around the actual codes, we need to establish exactly where these codes apply, right? The CPT guidelines explicitly define the scope of nursing facility, or NF services. And, this category doesn't just cover your standard nursing homes. These codes are actually used to report EM services for patients in skilled nursing facilities, or SNFs, as well as psychiatric residential treatment centers and intermediate care facilities for individuals with intellectual disabilities. So no matter which of these specific locations your provider is practicing in, this is the exact code set you'll be drawing from. And this brilliantly illustrates one of the most helpful changes in the whole 2023 overhaul. We saw a lot of consolidation just to reduce the administrative headache for clinicians. First off, notice that the old legacy code, CPT 99318, is gone, just completely deleted. But the absolute biggest conceptual shift here is how we handle care transitions inside the facility. In the past, moving a patient from a skilled nursing facility level of care down to a standard nursing facility level could cause a ton of confusion. Well, under the new guidelines, a transition between SNF and NF levels of care constitutes a single, continuous stay, period. It does not trigger a brand new admission. That is a massive simplification, and it takes so much ambiguity right out of the equation. Moving right along to Section 2, Initial Nursing Facility Care. Let's look at the admission phase. So these initial nursing facility care codes represent that absolutely crucial first comprehensive assessment, right? This is where the patient's overarching care plan is established. But listen, the rules for who can bill these and exactly when are super strict. These visits must be performed by the principal physician or the qualified healthcare professional who is actually overseeing the patient's care in the facility. Furthermore, these initial codes can only be used once per admission per physician or provider group. That's regardless of how long the patient's stay is. If another specialist happens to come in and see the patient on that exact same day, they cannot bill the initial care codes. They'd have to use subsequent care or consultation codes depending on the scenario. And remember our golden 2023 rule. You select your code level based on either medical decision-making or the total time spent on the date of the encounter. So let's actually look at the specific codes for that initial comprehensive visit. You've got a 3-tiered system: 99304, 99305, and 99306. If you're coding based on medical decision-making, 99304 requires straightforward or low MDM. 99305 requires moderate MDM, and 99306, that requires high MDM. Now, if your provider prefers to code based on time, the thresholds for the date of the encounter are 25 minutes, 35 minutes, and 45 minutes respectively. It's that simple. The provider just chooses the higher supported level based on either the complexity of their MDM or the total minutes they documented. Now, what's really interesting about this is how the AMA explicitly defines high medical decision-making for this specific setting. When you're trying to justify that top-tier 99306 code based on MDM, the guidelines recognize a very strict, very specific condition type. They defined it as multiple morbidities requiring intensive management. So we aren't just talking about a patient with a few stable chronic illnesses here. This means the patient has a set of conditions or functional impairments that are highly likely to require frequent medication changes or treatment reevaluations. Basically, the patient is at a significant risk of worsening medical or behavioral status, and they have a very high risk of needing to be readmitted to a hospital. It's a very targeted definition. So absolutely make sure your providers are documenting that high risk of hospital readmission if you want to support a 99306. All right, on to Section 3, subsequent nursing facility care. This is where we get into the daily management and rounding. Let's move to and see how this builds out for those subsequent daily rounding visits. Here we actually have 4 codes, 99307 through 99310. What you should immediately notice here is how dramatically the time thresholds drop compared to the initial admission. I mean, look at this. For a 99307 with straightforward MDM, the time threshold is just 10 minutes. A 99308 with low MDM is 15 minutes. A 99309 with moderate MDM requires 30 minutes. And that highest level, 99310 with high MDM, requires 45 minutes. And honestly, these lower time thresholds make total sense, because at this point, the provider is managing an established care plan, not building one totally from scratch. I really want to pause here and just re-emphasize the absolute core philosophy of the 2023 update. You must choose one basis for your code selection. It's either MDM or it's total time. They are mutually exclusive for determining the level of a given encounter. Now, yes, a medically appropriate history and physical exam are obviously still required to establish the medical necessity of the visit. You can't just skip them, but you do not count bullet points for the history and exam to pick your code level anymore. If the documentation happens to include both a really robust MDM and extensive time, the coder's instruction is simple. Pick whichever method supports the higher level code. Section 4. Nursing Facility Discharge Day Management. Let's talk about the final stage of the patient's stay. Okay, so discharge day codes are entirely time-based. But what exactly counts toward that ticking clock? Well, the guidelines state that discharge management includes the final face-to-face examination of the patient, any discussions of the stay, care coordination, providing continuing care instructions to caregivers, and all that fun administrative stuff. Preparation of discharge records, referral forms, writing prescriptions, the whole shebang. Now, here is a vital tip you need to remember. The time spent on that discharge date does not have to be continuous. So a provider might examine the patient in the morning and then sit down at their desk in the afternoon to write the prescriptions and finish the discharge summary. As long as it happens on the same date, all of that time aggregates together. So the crucial point is choosing the correct code based purely on crossing that 30-minute line. There are only 2 discharge codes to worry about. CPT 99315 is what you use when the total time on the date of the encounter is 30 minutes or less. On the flip side, CPT 99316 is used when the total accumulated time is strictly more than 30 minutes. It's a really simple binary choice, but it relies entirely on the provider explicitly documenting their exact time spent. Seriously, if they just write discharge complete, an auditor is likely going to downcode you or deny the claim altogether simply because the time wasn't proven. Finally, Section 5. This is our audit alert section. Let's talk about top audit red flags and billing compliance. I want you to stop and ask yourself right now, are your practice's nursing facility claims truly audit-proof? Because with the 2023 rules in full effect, auditors have very specific criteria they are hunting for. So let's take a look at the most common, high-stakes vulnerabilities we're seeing out in the field. Here are your 4 major red flags. Number 1. Reporting the initial care codes, that's 99304 through 99306, more than once per admission for the exact same specialty in the same group. Remember, you're only allowed to do that once per stay. Number 2, treating a step down from a skilled nursing facility to a standard nursing facility as a new admission. Like we talked about, that's one single stay. Do not bill another initial care code for that. Number 3, failing to document the exact minutes for those time-based discharge codes, 99351 and 99316. And number 4, improperly unbundling hospital services. Look, if a patient is discharged from the hospital and admitted to the nursing facility on the exact same date by the exact same provider, you have to follow strict rules. You usually bill a hospital discharge and the initial nursing facility admission separately, for sure. But you must ensure your documentation clearly supports 2 significant, separately identifiable services. Often, that means correctly utilizing a modifier 25. You really have to think carefully about these transitions of care. The exact moment a patient physically moves from the hospital to the nursing facility, or even just changes care levels within the facility itself, that is exactly where coding errors happen. It's like a trap waiting to spring. Securing your billing transitions requires rigorous documentation and a rock-solid grasp of whether you are reporting a totally new stay or just managing an ongoing one. The CPT guidelines are actually very clear on this now, but your provider's documentation has to reflect that clarity if you want to protect your practice's bottom line. Understanding the subtle nuances between initial and subsequent care, recognizing those strict criteria for high MDM in a facility setting, and flawlessly documenting your discharge time, this is exactly how you master the 2023 guidelines and protect your practice from those dreaded audits. So I'll leave you with this question. What processes are you going to implement today to make sure your very next facility claim doesn't get red flagged by an auditor? Don't forget to like, share, and subscribe to Decode Healthcare with Harshal.